بسم الله والصلاة والسلام على رسول الله. Welcome all medical students. We are going to talk about Goiter in this lecture. Our specific learning outcomes are define Goiter, classify Goiter, describe etiology, pathology, clinical features, investigations and differential diagnosis of Goiter, discuss management of different types of goiter. So the goiter is defined simply by visible thyroid. So if you inspect a patient's neck and you find that the thyroid is visible, that means this is goiter. To diagnose this goiter, you have to know the general etiologies and general pathologies for goiter itself. So you can know this by classification of goiter, and according to that you can move and take your history, physical examination, and you do investigations. So the goiter can be nodular. That means there are nodules, either multiple or solitary nodule as a single nodule. Both of them, either multiple or solitary nodules, can be simple and can be toxic. We mean by simple that these nodules or this nodule, it doesn't or they don't excrete more than requirements of the body of the thyroid hormone. So that's what we mean by simple. Toxic means that this nodule or one of these nodules or more than one of them is secreting more than body requirements for thyroid hormone. Both of them, either simple toxic, either it is multi or solitary, it can be benign and it can be malignant. So your aim, once you see goiter, to see if it is nodular or not nodular first, and then you will look for, is it multiple nodules or one nodule? After that, you will evaluate the patient whether it is simple or toxic. And at the end, you have to define, is this benign or malignant? Goiter also can be diffuse. And this diffuse goiter can secrete more than the requirements of the body of thyroxine, and we call it toxic. And this is clear in Graves' disease. Or it can be simple, so it doesn't excrete more than what the body requires of thyroxine. It just increase the formation and production. Rather, it increased the production and the secretion of thyroxine due to some physiological changes in the body, like puberty and pregnancy, and this is, we call it physiologic. Diffuse goiter also can be hypofunctioning thyroid. So the amount of the thyroxine is lower than what the body requires. And here it is very clear in inflammation of the thyroid. The most common cause is Hashimoto's thyroiditis. General evaluation of goiter. If you have a patient with goiter, you will evaluate this patient with aims in your mind. The first aim is it nodular or diffuse? And then you will see, is it multinodular or single nodule? And then you will see the function of the thyroid, and then you will make sure about the presence of malignancy in this goiter. So these are your aims. First, as we said, is it nodular or diffuse? And then you will see the function. And the third thing, you will roll out the malignancy. So this is the general strategy of evaluation of goiter. In the history, you will go for history of the mass itself. Usually it is anterior neck mass that move with the swallowing. Sometimes you have to ask the patient to swallow before you continue with the history of the patient. You will see, is there any pressure symptoms and changes in voice? This is usually malignant. The change in voice is usually malignant because of the invasion of the recurrent laryngeal nerve. And you will take history of the function, whether it is hyper or hypothyroid, and the risk factors of thyroid malignancy, history of radiation, and family history of thyroid cancer. We prefer to see this in the history of presenting illness of the patient. And here from the history, you can see that you get all of aims of the evaluating a patient with a goiter. And usually, as mentioned in the clinical skills, that 85% of diagnosis will be very clear from the history of the patient. So here you will see that the type of this swelling, its local effect, the function of the thyroid, and the risk of malignancy. Then you will do physical examination, and you will start by inspection. Usually will be a mass in the anterior neck that move with the swallowing, and you have to ask the patient to protrude her or his tongue to make sure this is not thyroglossal cyst, because thyroid will move with the swallowing, and thyroglossal cyst most likely will move with the protrusion of the tongue. Then you will go and inspect the patient from front for the trachea, and you will palpate also for the trachea to make sure that it is central and it is not deviated by the lump or by the mass. And you will look for tenderness. Then you will characterize the lump, like its size, and you will make sure, is it in one side, single nodule, multiple nodules, or it is diffuse goiter. The patient will be in sitting position, and you will go at the back of the patient to palpate the thyroid from the back. And you will put your palms, and you will put your palmar surface of your fingers on the thyroid, and you will start characterizing the nodules or the goiter itself. And you will talk about the surface of the thyroid, and also you will examine the posterior aspects of both lobes. You have to check all lymph nodes according to the groups, and you'll go for a specific signs like signs of hyperthyroidism, signs of hypothyroidism, and also signs of pressure like Pemberton sign and percussion for retrosternal extension. You will investigate the patient by radiology. You will do ultrasound, which is the mainstay of diagnosis in most of the goiters, and it will give you the characteristic of the thyroid. Is it single nodule, multiple nodules, or diffuse goiter? The CT scan will be done if there is chest. The CT scan of the neck will be done if there is a retrosternal extension or the patient having pressure symptoms. And actually, you can know that if there is extension by percussion of the sternum during physical examination. You will do nuclear scanning if there is abnormal thyroid function test with hyperthyroidism only, to see the area of the hyperactivity which secrete high thyroid hormone. Of course, you will not send the patient for nuclear scanning from the beginning. You will wait for the laboratory and you will go for thyroid stimulating hormone 3T4 and T3. We call this together thyroid function test. If I have a chance to do only one laboratory test for a goiter patient, I would do thyroid stimulating hormone, because if the thyroid stimulating hormone is high TSH, that means the patient is hypo, and this is the TSH coming from the pituitary. And if the TSH is low, that means is the patient is hyperthyroid, and this TSH value is regardless the 3T4 and T3 level. If I expect that the patient is having cancer, I have to do for them thyroglobulin because I will use this in the follow-up. Then if I expect that the patient having inflammatory process or autoimmune disease, I have to do thyroid disease related antibodies. Also in cancer, I have to do anti-thyroglobulin antibodies to make sure that the thyroglobulin is something I can rely on while I'm following up my patient. If there is indication and the thyroid function test is normal, or the patient is hypo, then I can do for this patient fine needle aspiration cytology from their nodules if it is indicated, and we'll talk about indication later on. Why shall we make sure that this patient is not having hyperthyroidism? Because maybe the fine needle aspiration will make complication for the patient like thyrotoxic storm. So that's why I have to do the thyroid function test before I send the patient for fine needle aspiration, even if the nodule is suspicious for malignancy. Now we'll talk about every type of goiter separately. So as we said, if I have a patient with goiter, maybe it is nodular. If it is multinodular, whether it is simple or toxic, we'll talk about simple here. So if you look at this diagram, which is taken from the classification which we talk about it at the beginning, if I have a patient, I can present this patient like simple multinodular goiter. Or a patient having single nodule or solitary nodule, I can say simple solitary nodular goiter, and etc. So this is the use of that classification, which we talk about them at the beginning. Simple multinodular goiter, the most common etiology is the iodine deficiency or dyshormonogenesis, and this is genetic. Females are affected more than males. The nodules usually contain colloids because if the thyroid gland cannot form the thyroxine, the colloid will accumulate inside the nodule. Commonly, the patient will present with long-standing visible thyroid goiter, and some of them they will have pressure symptoms because of the size, and it is related to the size. If it is too big, maybe it will make pressure symptoms over the trachea or over the esophagus, and the patient will have difficulty in swallowing and difficulty in breathing. Clinically, those patients are euthyroid because it is simple multinodular goiter. So simple means that the patient will be euthyroid. The swelling will move with the swallowing, of course, because it comes from the thyroid. And if you examine the patient, you will find that the patient will have multiple smooth surface, soft to firm nodules. The lab test which you will do for this patient is thyroid function test, which will be normal. So that's why it is simple. Ultrasound will show to you the multinodularity of the goiter, and you can do FNAC if you have any suspicious nodule. And there are indication of FNAC, general indication, which you can apply it also on the multinodular goiter. So I shouldn't take FNAC except I have indication of any nodule. And if I have more than one nodules suspicious for malignancy, I have to take every nodule alone. If the patient is complaining of the pressure symptoms, or you find that in your examination that there is a retrosternal extension, you have to do CT scan. The treatment of multinodular goiter is reassurance, follow up every 1 year with ultrasound and thyroid function test, and you'll do thyroidectomy if indicated. The indication of thyroidectomy in multinodular goiter is thyrotoxicosis, pressure symptoms, and suspicious nodule for malignancy or malignancy. Complications of simple multinodular goiter: secondary thyrotoxicosis, that those nodule became toxic, so we call it secondary thyrotoxicosis, or maybe long-standing stimulation can end up with carcinoma while it is rare. So these are the indications of surgery in simple multinodular goiter. As we said, pressure symptoms or suspicious for malignancy. Now we'll talk about also nodular goiter, multiple, but we'll talk about toxic. And here also it can be benign or malignant. Also, like the simple multinodular goiter, so we have to make sure that there is no any suspicious nodule while we are evaluating a patient for toxic multinodular goiter. We have other names for toxic multinodular goiter like Blummer's disease or secondary hyperthyroidism. In other types of endocrine problems, we call secondary once it comes from the pituitary, for example. But here, the secondary hyperthyroidism is different. We call it secondary hyperthyroidism if we have multinodular goiter, which was simple and it became toxic, then we call it secondary hyperthyroidism. The main etiology is the chronic stimulation. Most of patients are middle age with long-standing multinodular goiter. The presentation is same as multinodular goiter plus hyperthyroid symptoms. You will find that the TSH here is low and free T4 may be high. The ultrasound will show you the multinodular goiter. If you have low TSH, such patient should go for nuclear study, which will be done by the radioactive iodine I-123 to check where is the hot nodule between those multiple nodules, and then you will do surgery accordingly. So for example, I have a patient with hot nodule in the left thyroid. I will do for them only left hemithyroidectomy, and I will do surgery to other lobe according to the indications. The treatment, we have first to prepare the patient, give the patient antithyroid medications, and this should be done by the multidisciplinary team with our colleagues in endocrinology to make the patient first euthyroid, and then you will do surgery according to the indication, and the extent of surgery will be guided by the indication of surgery. Now we finish from multinodular. We'll go to single nodule or solitary nodule. As we said before, it can be simple and toxic, the same, and it can be benign or malignant. Here we want to add important thing, that this solitary nodule can be solid and can be cystic. The cystic nodule is very rare in thyroid, and we mean by cystic nodule as a pure cystic lesion. Most of the cystic lesions are degeneration of the solid nodule. So that's why the cystic nodules are very rare in thyroid. But to make it clear, we have to know the approach for such patient after you do for them all investigation like TSH to make sure that it is not toxic, and you did for them, then you will take this patient for fine needle aspiration. If it is bloody or it is more than 4 cm in size, this will be indication for surgery, as there is a suspicion of malignancy. You can aspirate once and twice. If it recurs after second aspiration, this is also indication for surgery. So this is a general approach of pure cystic lesion in thyroid, and it is different from the degenerative lesion. The solid lesion, we will take it in details like simple and toxic, and benign and malignant. Solitary nodule, benign, usually it is adenoma, and most of the patients are middle-aged females, represent 95% of thyroid solitary nodule. It is very common that you will find, if you do screening for 50-year-old female population, you will find that 50% of them will have thyroid nodule. So the thyroid nodule per se as solitary nodule is very common. If you take, for example, a population of 60-year-old female, you will find that 60% of them, they have thyroid nodule. So you will add just percentage for the age. You will get the percentage of this population having thyroid nodule. Can be toxic, hyperfunctioning, and you will find in your examination abnormal swelling in a specific area of thyroid. You will find that the patient may be thyrotoxic if there is functioning nodule. Usually adenoma is well circumscribed and it is not hard, just fair. Lab test, thyroid function test, TSH and free T4 to make sure that this patient is not toxic, and to make sure that this patient doesn't have hyperfunctioning nodule. And ultrasound, you will look for the features of the nodule to make sure is this going with malignancy or going with benign nodule. Size, irregular borders going with malignancy, hypoechogenicity going with malignancy more than hyperechogenicity, and if there is central vascularity, because if there are malignant cells, they have ability to produce angiogenetic substances which will increase the vascularity of that area. And also you look for calcifications, which is very important, as microcalcification in this ultrasound will increase the suspicion of malignancy. And histopathologically, the microcalcification will be represented as samoma body under the microscope. This is hypervascularity also, and it is central. To say that this is hyperechogenic or hypoechogenic, the ultrasonographer will look at the muscle surrounding the thyroid and will compare it with the nodule. If the nodule is shining more than the muscle, they call it hyperechogenic. If the nodule is less than or dull in comparison to the muscle, then we call it hypoechogenic. If it is the same as muscle, we call it isoechogenic. Then, according to the indication, and you look for the features of the nodule, you will do the fine needle aspiration. We have to concentrate that even if it is multinodular and we have one nodule with features of malignancy, we have to take from this nodule fine needle aspiration also. Fine needle aspiration cytology is the most important tool to evaluate any nodule, whether it is solitary nodule or in multinodular goiter. The indication of fine needle aspiration in thyroid nodule can be summarized as size. Any nodule more than 1 centimeter should be aspirated and its cells should be examined under the microscope. The second indication, if the size is more than 0.7 centimeter, we have to look for risk factors. If there are risk factors like exposure to radiation therapy before, especially external beam radiation, or the patient having family history of thyroid cancer. In such cases, we have to evaluate the nodule by fine needle aspiration. And the second indication, if it is more than 0.7 centimeter, if the nodule is thyroid 4 and more, according to ultrasound findings. So we are following specific system, and it is the language between us and the radiologist. So he will follow the thyroid system. If the nodule is thyroid 4 and more, we have to do for such patient fine needle aspiration. The cytological analysis from the fine needle aspiration classify the nodule into 4 general diagnostic categories. Either benign, which represents 70%, indeterminate or suspicious, 15 to 20%, malignant, 5 to 10%, or non-diagnostic in 20%. And according to that, I can do surgery. Usually benign we observe, indeterminate, malignant, we will do surgery for them, and non-diagnostic we have to repeat it twice. We have to repeat that FNA twice in non-diagnostic category. As we said, the surgery according to the result of the FNAC and the functional status of the thyroid. Now we'll talk about solid solitary nodule malignant. It represents 5% of thyroid nodules. The incidence is 9 per 100,000 and increases with age, the plateau at 50. Females are affected more than males, and risk factors are radiation exposure, family history, and specifically for follicular cancer is iodine deficiency. Now we'll talk about the thyroid cancer. We have also to classify the thyroid cancer in a specific category. We have epithelial in origin, and we have non-epithelial. The epithelial, we can also subdivide it into well differentiated or undifferentiated. The well differentiated, they are papillary and follicular. These are the well differentiated tumor, which originate from the epithelial cells. And the anaplastic is the undifferentiated tumor. For medullary cancer is non-epithelial because it arises from the C cells, calcitonin cells of the thyroid, which embryologically comes from the neural crest. We have also lymphoma and very rare secondary and as metastasis from other organs. The papillary is the most common thyroid cancer, and it represents 70% of thyroid cancers. It is a cancer of young age group. Females affected more than males. Solitary nodule or cervical lymph node is the most common presentation. It can be found also as a single nodule in multinodular goiter, or it can be found in other diffusely enlarged goiter as additional pathology. For example, patient with Hashimoto's thyroiditis, maybe they will have papillary CA as single nodule also. The papillary cancer tends to metastasize to lymph node, and 80% are multicentric at diagnosis. Multiple genetic mutations were discovered like BRAF and like other genetic mutations. You can diagnose it by clinical evaluation. It will be solid thyroid heart, can associate it with change of voice, change in voice or pressure symptoms. Most of those patients are euthyroid, so they will have normal thyroid function test in the laboratory investigation. Ultrasound usually will show you more than 1 centimeter nodule, solid hypoechoic associated with microcalcification and with irregular border. Fine needle aspiration is diagnostic, will show orphan aniide bud nuclei or folded nuclei, or also samoma bodies. As we said, maybe you will find it under the microscope and it present the microcalcification on ultrasound. Treatment is usually total thyroidectomy and radioactive iodine ablation if indicated post thyroidectomy, and then you can give the patient thyroxine therapy as a replacement for the thyroid function, and at the same time it will decrease the TSH, because if I have higher TSH I will have a risk of recurrence, specifically in well differentiated thyroid CA. You can follow up the patient with thyroglobulin, and the papillary cancer has very good prognosis, 90% 20 years survival rate. Follicular represent 10% of thyroid cancer, occurs in elder age group. It presents the same presentation as papillary cancer. The incidence of the follicular cancer is more in the iodine deficiency areas, and it tends to have hematogenous spread, not lymphatic like papillary cancer. The Hurther cell variant of follicular thyroid cancer, we can say Hurther cell carcinoma, because Hurther cell alone is just a metablastic changes of follicular thyroid cells. And this is the only variant of the follicular cancer which tends to have lymphatic spread, and this type of cancer couldn't be treated by iodine therapy because the metablastic changes which happen in the follicular cell, which then became cancer, it doesn't uptake the iodine. Thyroid function usually normal with them. Ultrasound will show nodule with some malignant features. The FNAC unfortunately cannot differentiate between follicular adenoma and follicular carcinoma. So any suspicious of follicular cancer by the fine needle aspiration, you have to do a hemithyroidectomy for the patient. If I have nodule here and then the FNA shows that it is follicular lesion, you have to do hemithyroidectomy, and then after that, if it is malignant, then you will do completion according to the size if it is more than 1 centimeter, and if there are other risk factor of malignancy, you will do completion. Otherwise, you can follow up the patient of the other lobe to make sure that there is no another cancer appear in the future in the other lobe. Treatment, as we said, total thyroidectomy, iodine ablation because it is well differentiated cancer, and thyroxine can suppress and also as a replacement, and you can follow up the patient with the thyroglobulin. Medullary cancer represents 10% of thyroid cancer. 80% of medullary cancer is sporadic because the medullary cancer, according to etiology, can be sporadic or can be hereditary. The hereditary can be also subdivided into familial as medullary cancer alone, or with other type of cancer with multiple endocrine neoplasia type 2. It is tumor of parafollicular cells or C cells associated with RET oncogene mutation. The sporadic is less aggressive than familial or inherited. Patient will have high calcitonin, so you have to check the calcitonin. Can be diagnosed by fine needle aspiration. The treatment is total thyroidectomy with central neck dissection. In the well-differentiated cancer, especially papillary, we don't do neck dissection except I have lymph node metastasis and it is approved by the FNA from the lymph node. But here in the medullary cancer, I have to do prophylactic central neck dissection because the percentage of metastasis to the central neck lymph nodes is very high. That's why I have to do for them from the beginning total thyroidectomy and central neck dissection, and they have to do for such patient, as we said before, surgery, calcitonin and CAA, just to follow them up and to see if any of them increased. That means there is recurrence. Anaplastic is very aggressive tumor, represent 2% of thyroid cancer. Fortunately, it is usually seen in elderly people. It is undifferentiated tumor, and most of the theories said that it originates from long-standing papillary cancer. It associates with very poor prognosis and present with a rapid growing tumor associated with pressure symptoms. Sometimes you need surgery in such patient for debulking only to relieve the symptoms of the patient, but generally the treatment of anaplastic cancer is palliative treatment. Lymphoma is very rare, present in elderly female with history of long-standing Hashimoto's thyroiditis, can be diagnosed by FNA. If confined to one loop, can be treated by hemithyroidectomy and chemoradiation. Otherwise, If it is diffuse with obstructive symptoms, you can do debulking and then you will give the patient chemoradiation therapy. We finish now from the nodular goiter in general. And as we said, maybe you will find a nodule in diffuse goiter. And this will be taken alone as a specific or different entity, and you will treat it with the other condition the patient have, which we will talk about it now, and they are mainly treated in endocrinologist clinic rather than endocrine surgery clinic. So the diffuse goiter usually is a medical problem rather than surgical problem, except in a specific situation. We will talk about them now. So goiter, as we said, can be nodular or diffuse. Now we'll talk about diffuse. We have three types: either toxic, simple, or hypofunctioning. Toxic, like in Graves' disease; simple, as we said, like in physiologic, pregnancy or puberty; and hypofunctioning, like in inflammation in Hashimoto's thyroiditis. So we'll talk first about the simplest, the physiologic. It will be during puberty or pregnancy, and it related to increase the body requirement. The patient should be investigated to rule out other causes. If the patient having physiological diffuse goiter, this patient doesn't need surgery and doesn't need any other medical treatment. Just we will follow up the patient. The second we'll talk about it is Hashimoto's thyroiditis. It is the most common form of thyroiditis. 5% of females, they have some sort of Hashimoto's thyroiditis. It is associated with abnormal thyroid function test. So here the patient first will have, because of the inflammation, will make the gland secrete more thyroxine, and the patient will be first at the beginning of the disease will have low TSH. So the patient will be hyper at the beginning. After that, the patient will have normal TSH. Within few months, you will find the patient having normal TSH. And then the patient will be ultimately hypothyroid and will need thyroxine replacement by our colleagues in the endocrinology. Usually the thyroid will be diffusely enlarged and rubbery in texture. Sometimes it will be asymmetrical and can also contain a nodule. If I find a nodule in such patient, I have to investigate the nodule also. It increases the risk of lymphoma, and it is treated by thyroxine and surgery if indicated. The indication of surgery in Hashimoto's thyroiditis are obstructive symptoms or nodule suspicious of malignancy. These are signs and symptoms of hypothyroidism. Other types of thyroiditis is very rare, like bacterial thyroiditis, and we treat them by antibiotic and drainage if no improvement, usually with immunocompromised patient. Riddle's thyroiditis is a rare condition, can mimic malignancy on presentation because it is fibrosis of the neck and invading the thyroid and parathyroid rather than originating from the thyroid itself. Graves' disease is responsible for 75% of hyperthyroidism. The female to male ratio is 7:1. It is an autoimmune disease. The gland uniformly hyperactive and very vascular. Usually it is asymmetrically enlarged, but it is diffusely enlarged. The frequent symptoms are symptoms of hyperthyroidism, like hyperactivity, irritability, sweating, and others. Maybe diarrhea, thirst, feeling, nausea, palpitation, polyuria, and oligomenorrhea. Can be presented as infertility in some people. These are the signs of hyperthyroidism also. Here are signs also of hyperthyroidism, and as we said, they are medical problem, better to be taken from endocrinologist or from medical people. Here just we mention them to emphasize the role of surgery in such patient. The lab will show you low TSH, high free T4, and ultrasound you will have diffusely enlarged hypervascular gland. Nuclear scan increase uptake diffusely. The treatment first will be treated by our colleague in medicine, endocrinologist, by antithyroid medication or iodine ablation. Actually, there are a lot of complication of antithyroid medication, especially nimorcazole, will have side effect like agranulocytosis. That's why you cannot give it to the patient lifelong. Iodine ablation, the problem of the iodine ablation that it has high recurrence rate. So the best treatment for such patient is surgery, and usually we do for them subtotal thyroidectomy. Thank you very much.